guys, what's going on? It's Matt Palmquist with another great episode of Mind Split Cafe. I'm joined by Chris Stowers, my co-host and the founder of the podcast. And today we've got Dr. Brad Zehring, the Chief Medical Officer for the Monterey Behavioral Health and Trellis Recovery Center out of Phoenix, Arizona, joining us today. Thank you so much, Dr. Zehring. You are a blessing for joining this show and helping our hundreds upon hundreds of listeners that tune in every week. So thank you, Doc, for being here today.
Yes, thank you for having me.
Yes, thank you. I appreciate you coming out.
So let me ask you, being the Chief Medical Officer for Trellis and Monterey, what exactly do you do, and what is your specialty, and why are you here today? So you can kind of fill in for the listeners.
Yeah, good question. So as Chief Medical Officer, my role, you kind of break it into administrative and clinical. So administratively, I'm responsible for the medical department at Monterey Behavioral Health and Trellis. So overseeing medical protocols, policies, procedures, making sure whoever we're admitting to our facilities are medically, psychiatrically appropriate. And so kind of really the oversight. We also have psychiatric nurse practitioners and psychiatric physician assistants that I oversee as they see patients themselves. So chart reviews, kind of having conversations with them. And then I'm also seeing patients as well. So I'll see admissions, do psychiatric evaluations. I'll do follow-ups on them. I am the psychiatrist for Trellis Recovery Centers. So it's a residential eating disorder facility in Los Angeles that I'll see. I'll talk to them, and that is also my passion. So eating disorders is my passion in psychiatry. So psychiatrists treat all mental illnesses. Eating disorders are it's a niche, and it's not. We don't learn as much as we should in medical school about them. We definitely don't learn as much as we should in residency about it. And so it's something that's taken some time to specialize in. And that's kind of where my focus was and what's bringing me on the podcast here today.
Well, we're glad to have you. We're glad to have you. I know that you've kind of been having a conversation with Chris, and y'all found each other on LinkedIn. So anybody listening, if we don't cover something that you have a question for Dr. Zehring, you can find him on LinkedIn like Chris did, right? And so what exactly is okay, so my question, I guess it's for the everyman, right? Like sometimes I'm not hungry, sometimes I overeat, whatever, right? That's life. But what is it exactly that defines an eating disorder? You know, like what is that? Where does it draw the line?
Yeah, it's a good question. And so what we need to delineate between is disordered eating and eating disorders. So disordered eating can be something where somebody is on the verge of strict diets, fad diets. Maybe it's interfering in some of their life in some way. We would just say, they're afraid of certain foods doing certain things, right? But it's not really affecting their everyday life. It's different, right?
Yeah.
Or disordered. Eating disorders, by definition, have to really cross a threshold of creating problems in personal lives, professional lives, occupational, social, and we see four main eating disorders. So anorexia or nervosa is severe restricting, to the point where people just can't choose to have anorexia. It's a biological brain-based disorder.
Wow.
That their drive to not eat and the pleasure they get from that is like our desire that we get from eating. So it's switched backwards, right? And so they also have a distorted view of themselves to the point where it feeds into that eating disorder. There's bulimia nervosa, which is restriction, binging, where somebody's eating too much to the point of severe making themselves sick. They can't stop, they can't think of anything else, and then they'll have to purge somehow. So vomiting, diet pills, laxatives, exercise, etc. There's binge eating disorder, which is the restriction and the binge eating. And then there's a newer eating disorder. It's called ARFID. It's avoidant restrictive food and intake disorder, which is similar to anorexia in that there's a lot of restriction that happens, but where anorexia nervosa is driven by a fear of being fat, wanting to be thinner, ARFID, they don't have any body issues. Their issue is either textures are such that they don't eat, that they are fearful of getting sick. So maybe they had the stomach flu from something once, and then now they're afraid of ever having that again. Or they're just really, really picky eaters. And we typically can see that in their family history. Like uncle was a picky eater, father was a picky eater. But the problem with that becomes they have nutritional deficiencies that happen. They can have failure of growth, height. And so it can be problematic too. And so when we start seeing the severity of food, the relationship to food, the relationship to body, it really crosses over all these thresholds that is different than disordered itself. That, and we could talk about how there's a lot of people that probably have a disordered relationship with their food and their body. But we try not to over pathologize that.
Well, I can already tell you got 4 episodes coming, right? Because we could take an episode and we could dissect every single one of those disorders, right? And forgive me if I don't remember them right off the top of my head, so I might ask you again. But you've got, we could take an episode every 30 minutes and just dive into one of those, correct? Because when I heard about the 4th one, which was called
ARFID,
I immediately thought of, and again, forgive me because I'm simple, but I remember being about 7, maybe 6 years old, and my mom made shredded carrot salad with raisins. And you had said texture, or you said something that you had eaten, and to this day, and I'm 45, so it's almost 40 years, I will not eat carrot salad because I remember getting sick. Now, it's not my poor mom's fault, I get that, but there could have been a lot of variables. But what I'm getting to is I associate that salad with the sickness that I got, and to this day I will not eat carrot salad.
Right.
Now,
almost like a trauma.
Almost like a trauma, correct? Now, obviously, my fat ass, I love food, so I'm not gonna, but is that trauma? Does that fall in line with that 4th, disorder, or is it just me being kind of like one-off?
So it's kind of one-off. So, but it's similar to that in the one case but it's multiplied by almost every single food. Right. So it's anything that's soft. It's anything that is crunchy. It's different because it could be texture, smells, tastes, right? It could be in that category of aversion. So there's an aversion to foods. And so what you may see is they'll only eat macaroni and cheese and chicken tenders, right? They can only have that. They'll eat nothing else in their whole entire life, right? And so, or they won't deviate. And so really what you have to do is you have to slowly introduce
other foods,
very slowly, and manage all the other anxieties and things that could potentially come from all of that.
Now, does economics come into play? If you're in a socioeconomic status where maybe affordability of foods, or the ability to access food, does that come into play? And the other question I have is, does the environment come into play as well? Like if you're going through a bad breakup, or you're in a really, mental place where you're not feeling great emotionally, and does it morph into, does it transfer over to now it becomes a disorder as far as an eating disorder?
Right. So so food scarcity has to be taken into account into these. So if you can't diagnose somebody with ARFID if there's been food scarcity in their environment. So like if they only had the ability to have and purchase certain foods and they only ate that, then that's not an eating disorder itself. So food scarcity can't be a part of that. Now, food scarcity is an interesting component because there's a lot of research that's coming out that food scarcity and growing up in that has very close ties to binge eating disorder. Because what happens is growing up, you have this, you don't have food. So you're eating everything you can get when you have it in front of you because you don't know when your next meal is going to come. And so what we're seeing is pathology of later in life, the trauma of food scarcity and the trauma of not knowing where your food's coming from, leading to certain things like that. The second part of your question about, we're really looking at months at a time. So we're not just looking at what the behaviors for a week or 2 weeks. We're really wanting to see a pervasiveness of when I'm talking to somebody, I'm saying, hey, how long has this been going on? I'm really looking at 3 months.
Okay.
But I'm even, I'm taking that 3 months into context. What were other things that were happening? Is it an acute grief? Isn't it an acute stressor that's causing these certain things? And then, we're going to look and try to treat that and getting that under control. And then we're going to watch, do the eating concerns, the food concerns continue from that? Then we're going to continue to watch that. But really the eating disorders are very complex. So we talk about mental illness as a biological, psychological, social, and spiritual model.
I was just about to bring that up. You took it out of my mouth, man.
And so when we think about food and we need food to survive. And so it's a fundamental thing for people. And so people that have an internal conflict with food in their body typically are going to have a lot of other, depression is going to be a part of this. OCD can be a part of this. Anxiety can be a part of this. Trauma can be a part of this. And so really trying to lay it all out and sifting through all of that. It's really important for the treatment of the eating disorder itself, but also understanding what's playing into what.
Wow.
So now that you brought that up, I was going to bring up biopsychosocial model, but that's because our previous episode was on substance abuse.
Mm-hmm.
So what I wanted to ask you is anything that happens with substance abuse and the treatment of substance abuse, or even the starting, why you start or get involved in substance abuse, does that play a part in eating disorders as well?
Yeah, absolutely. And substance use disorders are very co-occurring in eating disorder. And oftentimes what we have to watch out for and look out for is not just treating the eating disorder in that situation, because they can ping pong, right? So if you're treating the eating disorder, then their coping mechanisms can fall back to the substance use disorder. You're just treating the substance use disorder, they're going to restrict, or they're going to take control.
It's going to go back and forth. Yeah.
It goes back and forth. And so you really have to treat both at the same time. And really, when you get underneath both of those, a lot of the common threads, trauma, right? And so then, it used to kind of old science was you need to treat the eating disorder first before they can be stable enough to work on their trauma. And now what we know is similar to what we just talked about in substance use disorders and eating disorders. We have to work on the trauma at the same time we're working on the others, because
the trauma is the cause and the eating disorder or the substance abuse is the effect, right? And so you've got to peel back that onion to get through those layers to find out why it is what it is, right?
Yeah.
Brittany's gonna like you use that one.
Come again?
Brittany's gonna like you use that analogy. She used that in her episode.
She did.
You're learning, man. I like it.
Yeah, she did.
Yeah. And so, and through that, it's also teaching them, the eating disorders, another layer that's difficult. And similarly in substance use disorder, both eating disorders, they don't like to feel feelings. They don't like to feel their body. They don't like their body, right? And so helping them to regulate body anxiety, body trauma, because it's not just in their mind, it's a body disorder too. It's, working on these skills and really helping them somatically be able to soften the fight or flight, that's happening, or their freeze, helping them to get into their body and to be able to regulate is very important too. So
now, is it something that's always going to be with them? Like, I mean, if I came to your facility in Arizona and I needed to be a patient for whatever, for one of these disorders, is this something that I'm going to carry on for the rest of my life and that I'm going to have to cope with and find ways and tools to manage? Or is this kind of like, Doc, you're going to show me how to deal with it, and then eventually, I form the good habits, and then it just moves on to where it's no longer an issue 2, 3, 4, 5, 6 years down the road?
Yeah, it's a good question. What makes it difficult is we can't abstain from food, right? So
Yeah.
that's what so the most direct answer to that is the earlier that we get this, the better the chances are of remission happening, right? So I often talk about eating disorders like cancer. If you find cancer early and get rid of it, you're good. If it metastasizes and spreads, you have a longer, course ahead of you.
Yes.
And so that's it's similar. We see, so there's something in eating disorder field called severe and enduring eating disorders. And typically, the definition is not fully settled, but we're thinking about 20 plus years of having an eating disorder. These patients are very sick, and probably a lot of them may not recover from their eating disorder. Now, can we help them with their everyday life and the value they get from life? Yes. The eating disorder may be part of that. Now, in the other subsect, if we're getting to people early, we're getting them their good treatment, we're really understanding the purpose of their eating disorder, there's a good chance of full recovery, right? They're going to need to be conscientious of red flags, of things in life, but there's a good chance of that. So and then what's their psychiatric comorbidity, right? So what other things are they dealing with? If they have fewer psychiatric co-occurring, again, better. If they have more, increases your risk factor, increases the kind of the burden of what they'll be dealing with. So it's kind of a complex answer, but yes, the hope is to get people into full recovery.
Of course.
Yeah.
How important is environment? Like, I come from a sports background, right? And so you've got to have a great team to win a championship. I guess that's the best analogy I can have, right? You can have teams with star players and they don't win anything, but if you've got a collection of really, really, supportive and you've got a great team, you can win, correct? Yeah. How important is that as far as what you deal with when a patient comes in and you notice that they might not have that support team, or their support team or the people in their environment is kind of a cause or a factor into why they're sitting in front of you? Like, how does that play into it?
Yeah, it's definitely a part of it. And it goes back to the biopsychosocial. So we have a saying, in genetics load the gun and environment pulls the trigger, right?
Wow.
So it goes hand in hand with each other. And really what that means is we have to look at the environment as well, right? What is the environment that they're in, and how is that perpetuating the cycle? And so the most successful cases that we have are when family members, loved ones aren't saying get that patient better. They're saying, how can we work also on the things that we need to do to help the situation as well? When everybody is seeing themselves as a piece to it, then it really starts rolling well from that. But
how difficult is that conversation to have with like a mom or a loved one that is so defiant on kind of like that other side of the coin, where it's like, no, it's my daughter's problem. It's nothing that I've done because I was raised the same way I'm raising her. Like, how difficult is that to have conversations with those loved ones?
It's a simple conversation. What makes it not easy at times is when loved ones, parents don't have any insight, or they're defiant, or they don't want to hear it. That becomes tragic. But there are cases where you'll have them be defiant at first, or they don't understand it at all. They don't understand mental illness. They think, pull yourself up by your bootstraps, get over it, and then, but through family therapy and through conversations, you can see them, the light bulb sometimes goes off. But yeah, it can be difficult, and the patient suffers when somebody that's in their network is closed off to the idea or doesn't have any understanding. So yeah, family therapy is a huge piece, and really that's a buy-in from everybody. Is everybody going to buy in to say, this is a community problem, what can we all do to help this? That's to
find the success, to win the championship. Pretty much, like,
exactly.
how do we all buy in? That's amazing stuff.
So I have a question on treatment. I know that a lot of, and hopefully this isn't too invasive, but a lot of mental health issues have two sides of the coin. You have your talk therapy type modalities, and then you have your medical side of it. Obviously, you being a psychiatrist, you're on the medical side. What does a treatment look like for a various type of eating disorder?
Yeah. So you're gonna have different levels. So you're gonna have outpatient, which is you're in the life of the patient. You have intensive outpatient, which is a step up from that. They're going to go to a facility. Typically it's like 3 days a week, maybe 3 hours a time. There's partial hospitalization that's still at a facility, but then they're going home at night. It can be 5 to 7 days a week, 6 to 8 hours a day. Then there's residential, which is 24/7, you're somewhere. And then there's inpatient, medical inpatient, which means either you're too psychiatrically acute or too medically acute. So you're having 24/7 monitoring on a heart monitor. People are watching you. So that's kind of the scale of that. And so in outpatient, what we really push for is a psychiatrist, a primary care physician, a therapist, and a dietitian.
Mm-hmm.
Really having those 4 people is very, very important for oversight. And then a new thing now is coaching, right? So there's kind of was born out of the pandemic where therapists couldn't practice cross state lines because of license. So they would become a coach and maybe wouldn't do therapy, but they're and so that's an important piece to this too. And then family, of course. But in higher levels of care, so IOP, PHP, residential, you're going to have that team. You're going to have the psychiatrist, you're going to have a medical provider, probably family medicine, internal medicine, pediatrics, and somebody that's younger than 18, therapist, and a dietitian. And then mental health workers are going to be there to support as well. So really it's all encompassing of all the disciplines that will be there.
In fact, fantastic answer, but something kind of stood out to me in your answer towards the end there. You said if you're prior to 18, right? My question is this: do you see all spectrums? Like, can your eating disorder be delayed? Can you see it happen in 40, 50-year-olds and they were fine up until a certain point, until their 40s, and then something triggered it? Or do you relatively identify the disorders at a preteen, teenage years, and then it's something they deal with for the rest of their lives?
It's a really good question. And, I think all of the answers are going to exist here. So most commonly, it's going to be younger age that's going to have it. So typically, if somebody's going to have an adolescence, around puberty, something happens. We still don't know, is it a hormonal thing that happens that kind of triggers anorexia brain?
Yeah.
But we see a shift there. You can definitely see it in young adults. So they go off to college for the first time, and maybe some people get worried about the freshman 15. And so maybe they restrict and go on a diet for the first time. And then they come home for Christmas and the parents are like, what in the world is this? Like, you're so, you've lost, and they're definitely afraid. Right. Typically what we see, because we definitely see eating disorders in 40s, 50s, 60s, 70-year-olds. And typically what we see in those when they're finally coming to treatment is they've lived with it their entire life. And they're so sick and tired of dealing with it and being consumed by it that they're seeking treatment at that time. And then there's the one-offs kind of where somebody's gotten really sick and they weren't able to eat, lost a lot of weight. People are commenting on, hey, you look great. And so then
they just try to keep it. Yeah.
But
how big of, and something you said, how big of a factor or what kind of role does social media play in the whole thing? Like, I scroll through my social media and it's with social media now, the algorithm targeting what you look for, what you like, those ads are now served up. How big of a contribution does social media play as far as a negative standpoint to it?
It's huge. And I don't think we have fully understood the breadth of all that it is doing, but we know that it's not good. And there's pro ANA websites, pro eating disorder websites, where they are glamorizing this type of behavior, as sickening as that is.
Oh
And
my
so one of the
gosh.
things one of the things that we'll do in treatment is we'll actually help the people, especially adolescents, but even adults, we'll go into their social media and settings and really show them how to eliminate certain words that the algorithm can find for them, certain images, and really help tailor their phone to have it not come into their feed and not be bombarded by it. But yeah, it's
That's
a
interesting.
huge problem.
I need you to show me how to get rid of those keywords on mine too, because my bad ass doesn't have a problem eating, but I almost feel depressed sometimes because I see, posts or people, and I get served these ads, and it makes me feel like a complete like
Bad
failure,
mothers.
you know. And so yeah, if you want to show me how to eliminate those keywords, that would be fantastic, right? Because I get depressed sometimes.
Yeah, I mean,
That's just me, right? I'm just sharing. So
yeah, and neurobiology is becoming, and I'm not an expert on this by any stretch of the imagination, but they're definitely showing how the constant feeds that we have and the scrolling that we're doing, our brains weren't designed to do that. And so the constant input of that, like you really recognize that. And it's a very true thing that happens. And so that's
Dr. Brad, you were amazing. I'm going to give you your flowers now. You were, not to take away from any of our guests prior, but you have definitely like opened my eyes to something that, I mean, I knew that there were eating disorders, and I'm not trying to discredit anything, but how deep it gets, like it amazes me. So
Yeah.
I really appreciate you coming on and taking the time to joining us today.
Absolutely.
Yeah, no, definitely. I learned a whole lot. Anything that I've ever known about eating disorders has been extremely surface level. So I
Exactly.
appreciate you coming in. I want to play devil's advocate real quick. I know we're running out of time, but you just mentioned that social media plays a negative role or can play a negative role. Have you ever seen social media play a positive role in someone's recovery of an eating disorder?
Yes. Yep. And that's a good point. There are websites, social media of body positive accounts and eating disorder recovery accounts where it creates community for people. And so that is definitely the positive spin to that. Without a doubt.
Is it one of those sites would not be the Nathan's hot dog eating contest Instagram, would it?
No
Because
way.
that and I'm just cracking a joke, right? My dad jokes, but I see that every July 4th, and I'm just like, I'm never eating a hot dog again, right?
Yeah.
And so
Yeah, I can tell you, I haven't eaten a hot dog ever since I first seen that show. That is beyond me.
the consumption is, I can't
Yeah.
deal with it. I can't deal with it. I was one time, fun fact, I was one time in a chicken fried steak eating contest, and I ate 6.5 chicken fried steaks in 30 minutes.
Wow.
And yeah, I'll never do that again. Yeah,
I would imagine.
yeah. So anyways, well, Dr. Brad Zehring, thank you so much for joining the show. You are welcome back anytime. And I mean, we've got to dedicate episodes just to every disorder,
Yeah, no
what do you think, Chris?
Yeah, I definitely think we need to do that. It's kind of like the substance abuse. We can break that down into 5, 6 different episodes and just stretch it out.
Yeah.
Definitely. Well, next time I'm in Phoenix, Rudy's barbecue on me, Dr. Brad. So I really, really do appreciate it.
Yeah, absolutely. Thanks for having me.
All right.
Thank you, Dr. Zehring.
Take care and tune in next week for another great episode with some powerful content from Mind Split Cafe. I'm signing out. Matt Palmquist is your co-host. Chris, take it away.
Appreciate it, everyone. Thank you for joining us again. We'll see you next week.